Hello everybody, I'm Jen, and this is Sodium in 5 minutes. Kind of wanted to start out with sodium just because it's the first number in the basic metabolic panel, and a lot of the time if you have a patient where there's any labs at all drawn, the sodium is going to be the first one you see, or one of the first ones that you see. To be honest, in the patients that you take care of, most of the time sodium is not going to be the primary issue, but I'm hoping that this presentation is going to allow you to gain a little bit of confidence in terms of being able to look at the labs and have a serious think about what's going on with your patient physiologically. So for sodium, as you may very well know, the elemental symbol for that is Na. And then in solution, so in other words in the blood, it's almost always going to exist as a positive ion. So that's why it has the little plus. If you're wondering why the symbol for sodium is Na when there's no Na in the word sodium, it comes from the word natrium, which is a very old-fashioned term for sodium. A lot of those little elemental symbols come from essentially like Renaissance alchemy era names. When we talk about the serum sodium level, our normal, you'll notice that it's a pretty narrow range. It's going to be about 135 to 145 MEq per liter. Every lab has their own normal range, so it'll vary a little bit, but generally that's what you should be thinking of. And I just want to draw your attention to the units here because there's two parts of this, right? There's the MEq, which is basically the amount of sodium, and then there's the liters, which is the amount of fluid, right? So this is a concentration, not just a big pile of sodium. And the reason that matters in particular is because the serum sodium is really about essentially osmolarity, right? And there's a lot of different things that contribute to the tonicity of the blood. If you remember the whole business about hypertonic, hypotonic, isotonic. But sodium is going to be the biggest and kind of the most important driver of that in most cases, and especially in just the plasma. So for that reason, the sodium level is essentially about the balance between osmol and water, right? And so when you think about the serum sodium being abnormal, I want you to think about disorders of the balance of water or the balance between water and solute. So if we have a low sodium level, so less than about 135, we call that hyponatremia. And if we have a high sodium level, so greater than about 145, that's hypernatremia. Hyponatremia, so that again, that's a low sodium, is pretty darn common. It's often mild enough to be asymptomatic, and it has a lot of different causes that we'll talk about in a second. By contrast, hypernatremia, so that's a high sodium level, is actually pretty uncommon. And the main reason for that is because thirst is a very powerful motivator. And if your serum sodium level starts to rise, then what happens is our brains release antidiuretic hormone and you get very thirsty and you immediately go and you look for some water to drink. And so generally you don't see a high sodium level unless the patient has been unable to drink water. So think about your elderly patients who have been stuck on the floor for 2 days because they fell down, or if the brain is busted enough that there's a failure of the thirst response. So you can see this, for example, in like very end-stage dementia patients sometimes. Now, in terms of hyponatremia, I promised to talk about the causes. So we're going to talk about SIADH, syndrome of antidiuretic hormone. That's essentially pretty much what it sounds like. It's too much antidiuretic hormone. We can see this with patients who are in pain or they have kind of post-surgical physiologic insult, and of course a lot of post-surgical patients have pain as well. You should also know that there are some cancers, primarily small cell lung cancer, that can actually secrete inappropriate antidiuretic hormone. Another big cause is low solute intake. So these are patients who are basically, their diet is very low in salt and protein, and so they're not even having enough solute intake to keep up for urinary losses. We can see this in what's called tea and toast syndrome, which is basically like elderly patients who are really only eating, bread and water, or the equivalent thereof. And then also sometimes in our chronic alcoholics, and we call it beer potomania, when they're getting a lot of their calories just from alcohol that doesn't have any protein or salt in it. We can also see hyponatremia and loss of intravascular volume or hypoperfusion. Essentially, just think of it as being, you have a loss of volume or a underperfusion of organs, and then you end up with an ADH response that holds back free water, and you dilute the sodium. You can see this in patients who are volume depleted, or patients who have like hypoalbuminemia and cirrhosis, maybe even congestive heart failure. And then you can also have excessive free water intake. I think this is kind of the most obvious way to get hyponatremia. You really have to drink a really large amount of water for this to happen, but you do see it happen sometimes in, like, maybe a patient who, was dared to drink gallons of water as like a frat hazing thing or something like that. The last thing I want to talk about real quick is what we call pseudo-hyponatremia, and this is essentially a low sodium but a normal serum osmolarity. Generally, we see this in our hyperglycemic states, so think about like DKA and HHS. In those patients where the glucose is very high, just know that there's something called a corrected sodium. You can find calculators for it, and you're going to act on that rather than the nominal sodium level. So that's sodium in about 5, or I guess really more like 6 minutes. Let me know if you have any questions on that.